We're here today with Sue Desmond-Hellmann, CEO of the Bill and Melinda Gates Foundation. Thank you very much for being with us today here at AEI.
Glad to be here.
You've done quite a bit. You had a public event this morning with Arthur Brooks, and I think you just finished up our podcast, and you did Facebook Live as well, which I didn't even know was going on. So we're giving you.
I've been everywhere at AEI.
Yeah. So thank you.
Nice new building.
Yes, it is. It's wonderful.
Here.
It's wonderful.
Yeah.
And this is, I think this is my first interview in our new TV studio.
Right.
So I'm looking at the equipment, a little camera that's skirting around on the floor. That's freaking me out a little bit, but I'll get used to it. So let's just dive right in because we don't have a ton of time. My first question kind of relates to what's happening at AEI amongst some of our younger people. It's graduate school application time. We're in the quarter life crisis period right now, and that's starting to resolve itself a little bit, and people are getting ready for their graduate school deadlines. You've had a really varied career, but it started as a physician. And I was wondering if you could just let us know why you wanted to become a physician.
Oh, I wanted to become a physician because I wanted to help patients. I was very motivated by my experience growing up with my dad, who is a pharmacist, and our family doctor, Noah Smirnoff, who was just a terrific guy. And seeing Dr. Smirnoff and my dad and their interaction with people and how much they help people was a big motivator for me. And then as I got older, I knew that I loved science and I loved math. And so going to medical school, I also got to take the classes I liked the most.
Well, that helps.
Which was useful.
Yes.
Yeah.
You credit moving to Uganda in 1989 to work on HIV/AIDS and cancer as a major turning point in your life. Why did you make that move in the first place?
In 1982, I became an intern in San Francisco, and in 1981, HIV/AIDS was first described. So like a lot of trainees in the 80s, my experience as a young doctor was incredibly impacted by the HIV epidemic. And my specialty as an oncologist was Kaposi sarcoma, the cancer that affects HIV/AIDS infected patients. And so when the world started to get worried about heterosexual transmission of HIV infection, the Rockefeller Foundation funded UCSF to study heterosexual transmission in sub-Saharan Africa. And UC San Francisco loaned my husband, Nick Hellman, an infectious disease doctor, and I to Makerere University in Kampala, Uganda, to start to understand what was going on that was very different than the experience in the U.S. had been so far, with the main population affected being gay men.
That's fascinating. And so that's how you got there.
That's how I got there.
It seemed like there was a lot of circumstance that kind of led you there. Once you were there, why did it become such a turning point for you?
In every way, it changed how I thought about the world. It changed how I thought about poverty. It changed how I thought about myself. I was able to be a leader in Uganda in ways that in a big university just didn't happen spontaneously. And I think the combination of those things, getting to be a leader and seeing how much human potential was really not able to live up to their capabilities because of that extreme poverty, that extreme disadvantage, I think I just held myself accountable for making a difference in the world in ways that just didn't feel real for me before I had that experience.
I see. The Gates Foundation strives to advance a vision of the world in which every person has the opportunity to lead a healthy life. What do you mean by health?
The most important thing that we mean by health is not to be threatened, especially from an early age, by things that are so consequential. So it just doesn't seem right to us that any child should suffer or die from a vaccine-preventable disease. That shouldn't happen in 2016, much less ever. So we're obsessed with vaccines in a very positive way. A vaccine-preventable disease might mean for a few pennies a child can go without measles, rubella, diarrheal disease, pneumonia. These are things that really have meaning for us. We invest in nutrition because we know that things like stunting and wasting decrease human potential, not just for the obvious things that you're weaker and smaller than you would be, but your cognitive development is not as much as it should be. So what we mean by health is stacking the deck in favor of that child being able to thrive, being able to learn, to have a job, to go to school, to have a life that we think anybody should have the possibility for.
Listening to your answer, which is very compelling, it reminds me of some conversations I've had recently with parents of newborns about vaccinations here in the United States. Mm-hmm. And I've read some news reports that whooping cough is breaking out in some parts of the country, which is really troubling. Do you have any thoughts you'd like to share on vaccinations here at home?
Actually, vaccinations and health prevention measures are something that, as a public health person myself, I think it's really, it's so important not to get complacent. Mm-hmm. And something that I think has happened in the U.S. is a certain amount of complacency about vaccine preventable illnesses. Things like measles, things like whooping cough. We tend to take for granted that those aren't problems anymore. And in most communities, they aren't problems because of vaccines. Mm-hmm. So it takes vaccination to prevent those diseases, which feels obvious. Mm-hmm. But if too many people opt out of vaccines, then we actually have a troubling fact, which is what should be completely gone, like measles, like whooping cough from places like the United States, can come back and come back fast and furious.
Mm-hmm. That makes perfect sense. Let me talk a little about your career. So you've had an extremely successful private sector career. You helped develop 2 of the first gene-targeted therapies for cancer. You were named by Forbes as one of the world's 7 most powerful innovators in 2009. And for 7 years, you were listed among Fortune's top 50 most powerful women in business. A lot of power there. What prompted you to? So you were really at the pinnacle, and then you left and became chancellor of a university. What made you want to leave the private sector and take a leadership role at a university?
Well, I had been president at Genentech for about 5 years. And in 2009, our majority shareholder, Hoffmann-La Roche, bought the remainder of Genentech. And so the company was the focus of what people call in the business world a squeeze out. And when Roche bought the company, it would have meant going from an 11,000 person biotech company in South San Francisco to being part of a 90,000 person international drug company. Mm-hmm. That wasn't as compelling to me as what I had been doing. And so the University of California, San Francisco, which is where I had done my medical training and fellowship, had asked me to look at the job as chancellor. Mm-hmm. And given that transition time for myself of going from Genentech to the Roche acquisition, I interviewed for the job, not thinking that they would select someone from the private sector, which was unusual.
Sure.
And so in 2009, I became their first female chancellor, which was a first, but I think a bigger first was the first private sector chancellor, because I had been 16 years in the private sector, but had an adjunct appointment and still taught at UCSF, at Stanford, and at UC Berkeley. I actually taught about portfolio management in the business school.
Oh, is that right?
Which was kind of funny to do that. But I enjoyed teaching, and I enjoyed scholarship. So it wasn't too crazy, but it was definitely unusual.
Do you think having so it is very unusual,
Yeah.
and do you think having a private sector background helped you to succeed as a university chancellor?
I think the private sector background was helpful, and I think I had a lot to learn. I'll give you one example that people who know academia would chuckle about. The concept of shared governance.
Yeah.
When I first heard
we have a lot of fun with that here, too.
Yeah, when I first heard about shared governance as being the faculty and the chancellor, I said, "Are you kidding me? Like, that makes no sense. Sharing is hard, you know." And so I learned a lot as chancellor about that. On the other hand, we had a major academic medical center. UCSF Medical Center is a big big medical center, and it's a big business. And so I definitely brought, during a really tough time, the big recession, a lot of business savvy to the university, which I think was very helpful. And I learned a lot about shared governance, about student life, about really thinking about things that I was either not very knowledgeable about or had to catch up on, like what it's like to work off of NIH grants, how to run a lab in a world where the resources feel small and the expenses seem big.
Yeah, and are growing.
And are growing. So I learned a lot more than I had remembered about academic life and what it's really like to be a faculty member in these times.
Yeah, it's not gathering a group of 22-year-olds at your feet and talking about Aristotle anymore.
No, it's definitely not that. And student life has changed a lot.
Yeah.
Student life has changed, and students' aspirations and their expectations are different than mine were when I went to medical school now a long time ago.
In what way?
I would say that students' expectations for how they have a well-rounded life, or how they have a life outside of medicine, in a positive way, is different than what I expected. I expected that I would be immersed in medical school and in my internship and residency. In fact, now there's laws that govern the hours of residence. Those laws didn't exist when I was in training.
Do you think those are good laws?
I think that those laws are generally good. I think it's really important for the health and safety of the patients you're caring for and for the residents themselves. There's some downsides to the laws. You have to do a lot of handoffs when you have duty hours laws, and the handoffs aren't good for patients and aren't actually good for learning. And so now there's a very healthy inquiry about how do you protect those trainees and the patients they care for while giving the patients that continuity that they got when I was in the hospital for 36 hours straight. So trying to make sure you get continuity and great training at the same time as you don't do things that I mean, if you just say out loud 36 hours straight at a job, you know that makes no sense, right?
The thought of being treated by somebody on their 35th consecutive hour always gave me the willies a little bit.
Yeah. No, I think those are things that you have to balance, and how you learn with supervision, so that I always used to say that one of the things that I learned in medical training is the difference between the hairs being up on the back of your neck and the hairs being up on the back of my neck. Like that sense that I'm on the spot and this patient's dependent on me, you need that in your training, but you don't want to put that patient at risk. Those are some of the nuances of medical training that are really tough. But the great news is, and I'd learned this as chancellor, there are experts in clinical education, be it medical, nursing, pharmacy, dentistry, which is the areas that are clinically trained at UCSF. There's actually a lot of scholarship on that now, best ways of learning, best ways of experiencing, so you can maximize technical proficiency and empathy.
Yeah.
Because we all want...
You got to balance.
We want a good doctor who has a good bedside manner as well.
That's right.
Yeah.
So one of your many contributions as a public intellectual is this concept of precision public health. What is that, and why is it important?
So precision public health for me is important because it takes the incredibly powerful concept of precision medicine, right drug, right patient, right time, and applies it to public health and global health. So you think about the right set of interventions for the right population in the right geography. If you're a minister of health in Ethiopia, you've got frontline healthcare workers who might have a 10th grade education, who might have limitations in budget. And you've got to pick 10 things that she has in her bag that she goes out and carries to somebody in her village. What should be in that set of 10 interventions? What belongs there? What should she be trained to do? That's a tall order. That is a tall order. So precision public health for me is the concept of using data and monitoring and feedback to give those caregivers and the decision makers in the Ministry of Health, no matter where you are in the world, or the Department of Public Health, if you're here in Washington, D.C., the right information to maximize the value of every penny spent on health in service of that community. It really is a transition from a highly individualistic, precise way of thinking to a more prevention-oriented, more community-oriented way of thinking about being productive with the resources, and including the human resources you have to keep a community healthy.
Do you have an example of where that's being done particularly well?
Well, actually, I think we all are seeing an example of how that can be done well with the Zika virus epidemic. If you look at how we know where Anopheles mosquitoes are, that's the malaria mosquito. We've used that for malaria control. The Aedes aegypti mosquito, which is the source of Zika and dengue fever and chikungunya, some of the things people have been reading about, we know where the Aedes aegypti mosquito is. We know where Zika has traveled. We know community by community. Yesterday, we knew that there was a case of Zika in Texas. That's precision public health, knowing precisely what community, where the patient was, what the transmission route was, and that allows caregivers and decision makers not to just say, okay, everybody in America should be worried about Zika. That makes no sense, and it's cost prohibitive. But if you know the very communities, you can target vector control, getting rid of the mosquitoes. You can target messages for women who are pregnant or who might become pregnant. You can target messages for males who can transmit Zika to their partners. And both the public health messages on the communication front and the interventions on vectors and virus can be much more precisely delivered. That's a good example of where with the right resources and the right data, we can make a huge difference.
So would it be fair to summarize this as getting the right information out and acting on it appropriately?
Absolutely. And it starts with getting the right information. It's amazing how often we're nearly flying blind. And one of the aspects that we've been investing in at the foundation is the causes of neonatal mortality. So there's a period of life, actually your most scary day is your birthday, the first day of life.
Is that right?
Under 5 mortality is the highest in the first day of life. And in too many of those cases, we don't actually know why those children are dying. If we had that knowledge, if we had the information, much better information on all causes of death in the first 30 days, only then can we more precisely give a remedy. I'll give you a really easy example. So group B strep is a bacterial infection that causes fatalities very early in life. If a woman's baby dies of group B strep, she has 7 times the chance that her next baby will also die of group B strep, this bacterial infection. And it can be prevented with penicillin. Pennies a dose, right? So that's a good example of where that data, that information, getting back to those communities. If you're seeing group B strep as a cause of mortality, that community needs penicillin for those women. So a really simple remedy. I'm not talking rocket science. I'm talking penicillin, for heaven's sakes. You would only do that if you were able to diagnose the group B strep.
Yeah, that makes sense. You mentioned Zika. Are you worried about pandemics in general? Do you think that the world is ready for a full-scale pandemic?
I'm very worried about pandemics. Since I've been at the foundation, the world has seen both Ebola and Zika. And the foundation didn't intend to invest or specialize in pandemics, but we've gotten very involved because it's clear to us and the global health community that the world isn't ready for the biggest threat of all, which almost surely is influenza. We have been lucky as a globe that Ebola is actually not as contagious as influenza, that Zika, while horrible for the families involved because it causes a terrible birth defect, is very limited, and in most people doesn't cause a difficult disease. It's much more like a flu. If the world saw pandemic flu, we are not ready. And so our foundation with the global community has gotten involved in governance issues, surveillance issues, and in getting better tools. We need better tools, be they diagnostics, therapeutics, vaccines. The world needs to have things in our toolkit so that we can respond more rapidly. What we found with Ebola in particular is that the vaccinations were ready when the epidemic was finished.
Yeah, that sounds worrying. So if this flu season turned out to be a really bad one, do you think we'd be able to step in and take the kind of measures that we needed to?
So the seasonal flu, we're on it. Seasonal flu, the Centers for Disease Control in the United States monitors the most common causes of seasonal flu, and the flu vaccination campaigns are appropriate in the U.S. There's always ways to improve that, and always innovations that can make seasonal flu vaccination coverage better. A pandemic flu, like the H1N1 and things that we've seen, that's a different nature. That would be a global flu, and it would be something that most worrisome would be it springs up in an area of the world that is an area of unrest or an area that doesn't have good standards of health. So one of the best ways to be ready for that is something that is in the Sustainable Development Goals that the world has put in front of us for 2030, and that every place in the world has a health system that works. It actually sounds like mom and apple pie, doesn't it? It turns out that if you want to be ready for an epidemic, having working health systems everywhere is extremely important. The health system in Liberia, in Guinea, in Sierra Leone, those health systems didn't work. So Ebola quickly got out of control, in no small measure because there was no working health system. To be ready for a pandemic, specifically a flu, having working health systems and surveillance that works globally is step one.
And how far are we from being able to effectively deal with a pandemic flu?
I would say that in terms of the global governance, there's already been an enormous amount of work since the globe came together on Ebola. And so there are, now we're at the kind of report stage and at the building global capacity stage. There's one of the efforts that we've been a part of is something called CEPI, which is the Collaboration for Epidemic Preparedness and Innovation. And CEPI is a way for people from pharma, from the not-for-profit sector, from academics to come together and say, what are the tools that the world needs to be ready for an epidemic? CEPI didn't exist before we had Ebola, before we had this knowledge that the world needs to get ready. There's also efforts at reform going on in WHO to make sure that WHO or others are ready for the governance. Who's in charge? Who's in charge when there's an epidemic? There's clearly a role for sovereign nations, but there's a need for global governance systems. What Ebola served as for the globe is a wake-up call, and I would say we're not quite where I'd like us to be, but the good news is even though we don't have an epidemic, the global community has continued to push for us to get ready. And always, like everything else in life, you get very focused and then you go on to the next problem. This has been now, Ebola a couple of years ago, a continuous stretch driven by really terrific people globally, but particularly great leadership coming from the UK, from the US, from Germany, and organizations like the G7 and the G20 have been part of driving that global agenda to make sure that the world is ready next time.
So we're not ready yet, but we're making progress.
I think we're getting better, yeah.
Let's turn to the United States. You're a physician, you're a scientist, you've been a university chancellor, a business executive, and now you're the CEO of the Gates Foundation. Taking the broad view, what are your thoughts about healthcare in the United States?
Oh gosh, for me, healthcare in the United States has been a big challenge since I went to medical school. People have been talking about healthcare in the United States. And there are many, many challenges, many of which I'm not an expert on. We don't do health in the U.S. Here's what I'm sure of. What I'm sure of is that working on prevention, working on the more public health aspects of health are a net positive, globally and in the United States. And yet, one of the biggest challenges with our health system is that we try and fix things after they exist. You know, I'm an oncologist, and so often I would be working to try and fix problems that were preventable. We don't know how to prevent all cancers, but we know how to prevent one of the most important ones, which is lung cancer, for example. So I think that in the United States, any future health systems discussion should come with a vigorous discussion of how do we enhance healthy behaviors? How do we enhance vaccinations, healthy diet, exercise, all the things we've known for a long time are good for human beings? How do we treat hypertension rather than deal with a lot of strokes or heart failure? These are things that public health knows, and yet one of the sad things for me is that public health has been under-resourced in the United States. That's a great investment.
So
That's a great investment.
You think with more resources we could get people to live healthier lives?
I actually think that we have lots of resources going to health in the United States. We spend a larger proportion of our GDP on health than any country on earth. It is how those resources are used and what they're spent on. So I hope this dialogue that I know will be upcoming on the future health system for the United States, I hope that those decision makers keep in mind the importance of public health and what a great investment it is, particularly for young people, to have public health that drives healthy behaviors and wellness.
Thank you very much for being with us. Thanks for all you've done at AEI today, and congratulations on all the success that you're having and the success of the Gates Foundation. And we look forward to watching the great work Gates is doing going forward.
Thanks a lot. Nice talking to you.
Thank you.